I'm Lexi. I'm the last third-year resident at McKay, so sorry you have to listen to me last. Today I'm going to be talking to you about managing cancer-related pain in patients with previous opioid use. This is just a brief outline of what we're going to go through today. So we're just going to review some basic terminology and go through 3 different studies that have been done recently in managing these patients. So first off, what is opioid use disorder? This is a pathologic pattern of behaviors related to opioid use. We see this a lot in primary care, especially in Porter Clinic for those former residents that are joining us today. These patients will have ongoing use despite the development of substance-related problems leading to significant impairment or distress in their personal lives. Similar to opioid use disorder is non-medical opioid use, and this is a broad spectrum of non-prescribed opioid use. This can be use of opioids without a prescription, use of opioids with a prescription but not as prescribed, or use of opioids intended primarily for the purposes of experiencing or feeling the feeling caused by taking the opioids. This term is similar to the term chemical coping, which refers to the use of opioids to treat psychological suffering or emotional distress. And patients with non-medical opioid use may get medications from their friends or family, buy them off the street, report them as lost or stolen, ask for early refills, request specific drugs when they're coming to see you, or resist changes in their therapy despite adverse effects from their use. They may also have ongoing alcohol or illicit drug use as well. So for any patient, especially those with cancer, the National Comprehensive Cancer Network recommends screening for aberrant opioid use. These behaviors might be compulsive use, preoccupation with their medications, overt cravings, loss of control, and continued use despite harm. So the National Comprehensive Cancer Network recommends using state-run prescription programs, REMR, at Intermountain's awesome because that's built into the system there. They recommend coordinating cancer-related pain with addiction specialists in patients with history of addiction. We should be educating clinicians on how to screen for these bad behaviors and educating patients as well for other services like support, cognitive behavioral therapies, etc. for managing their use. And if they have history of use, you want to have frequent patients with high-risk behaviors. And these behaviors might include history of illicit drug use, alcohol or substance dependence, family history of substance abuse, along with legal problems, incarceration, or psychiatric disorders. So for these patients, we also want to be evaluating them for psychosocial stressors. This can be depression, anxiety, psychological distress, and these all worsen the severity of their pain. It's kind of like this catch-22 cycle. What comes first, their pain or their mental health concerns, and they can kind of exacerbate one another. It also lowers their pain tolerance as well. So for these patients, you want to recommend that you're treating both their pain and their psychiatric symptoms simultaneously. So how does all this relate to cancer and pain? Up to 66% of patients with cancer will report some kind of pain, and this pain can be due to the cancer itself or due to their treatments, such as surgery, chemotherapy, or radiation therapy. Oftentimes, cancer pain is chronic, but these patients will have acute exacerbations of their pain related to these interventions and as their disease progresses as well. Over 50% of patients with cancer will be prescribed opioids at some point during their treatment, and this can improve tolerance of treatment and their quality of life as well. And then, patients with substance use are at higher risk for development of cancer. For example, smokers are at higher risk of developing lung cancer, and they may have opioid use going into it. So that makes it difficult. And patients with cancer commonly use opioids to dull the emotional pain and suffering they are dealing with their cancer diagnosis. And that goes back to the non-medical opioid use. So this is complicated because there's not great information that exists about managing opioid misuse or opioid use disorder in patients with advanced cancer. This could be because patients with advanced cancer have limited prognoses related to their cancer, so we don't have the availability to study them longer term and do great research on them. So kind of what we mentioned before, the co-emergence of cancer and opioid use develops from patients with a history of opioid use disorder that develop cancer, or patients that have cancer but develop opioid use disorder. To manage these patients, kind of like what Adam was mentioning in his topic, you want to do a multimodal approach with motivational interviewing, psychoeducation, different therapies, using non-opioid analgesics, and then there's some studies that are going out to use buprenorphine or methadone as well. For these multimodal therapies, you can think of exercise therapy, mindfulness, group support, spinal manipulation, acupuncture, and yoga. Sometimes that can be hard, though, for our patients that don't have access to resources to afford those different things. For the non-opioid analgesics, you can think of NSAIDs, antidepressants, and things like gabapentin and pregabalin as well, along with medical marijuana. That's becoming bigger to use. So, going on to our studies. This is a study 1, and just so they don't confuse, they're all color-coded on the top. This study was looking at the factors associated with non-medical opioid use behavior in patients with cancer who receive opioids for their pain. So the objective of the study was to determine the overall frequency and the independent predictors of non-medical opioid use among these patients. So this was a prognostic study to assess for non-medical opioid use, analyzing data from a cohort of patients from February 2016 to July 2018. This was from one cancer treatment center, and I believe it was in Texas, if I remember correctly. And they didn't need to get consent from any of the patients because the patient data was already stored in the EMR. So even though it was a prognostic study, it was going back in time and just looking at that specific time period. And they reviewed the documentation at the supportive care clinic for the presence of any behaviors in the patients that suggest non-medical opioid use. Participants were eligible for inclusion if they had cancer and were taking opioids for cancer for at least 1 week. They were excluded if they had no follow-up within 3 months of the initial consultation, didn't complete the appropriate questionnaire at the time of their intake, and did not have scheduled opioid treatments. From the results of the study, 19% of patients developed non-medical opioid use behavior with a median duration of 8 weeks after initial consultation. Usually it was just one behavior that was identified in the patients, with the most common development happening within the first 2 weeks. And the most common behavior that they noticed was unscheduled clinic visits or inappropriate refills. Things that affected the development of non-medical opioid use among these patients include marital status. So if they were single or divorced, they're at higher risk. Their SOAP score, which is just a score that they use to develop their pain, and their daily opioid dose or morphine equivalent dosing. Limitations of the study were that you could only use the data that was already stored in the EMR from that designated time period, and it was mostly women that were included in the study, so you couldn't really generalize it to the entire population, and it was only from one cancer center, so that made it unable to generalize as well. For our next study, we're going to talk about buprenorphine for cancer pain in patients with non-medical opioid use. This was a retrospective study that the objective was to assess the effectiveness and safety of rotation of buprenorphine for treatment of cancer pain, especially if they have non-medical opioid use. This was done in a palliative care clinic, and all the patients at some point were prescribed buprenorphine for their pain. Only 16 patients were identified to be included in the study, and of these patients, 75% were determined to have non-medical opioid use. The presence of non-medical opioid use was defined as the use of prescribed opioids to control emotional pain or non-nociceptive symptoms. From the study, rotation of buprenorphine led to improvement in pain scores, but they're not statistically significant, as you can see from the p-value. I don't know if can I go over here? And patients without non-medical opioid use actually showed greater improvements in their pain score compared to patients with non-medical opioid use. So the study aim was to hope that the patients with the non-medical opioid use would actually have lowered pain scores in general. Limitations of the study, again, the retrospective design made it difficult. It has a really small patient sample size with only 16 patients included. and the pain scale was only one pain scale was used, so it didn't include all aspects of pain, especially the psychosocial pain that develops. Our last study is a consensus-based guidance on opioid management in patients with advanced cancer and opioid misuse or use disorder. This is kind of the gold standard they're using right now for managing these patients. And the objective was to develop a consensus among palliative care and addiction specialists on how to manage opioids with these individuals. So this was a Delphi study, and essentially this is just asking people what their expert opinion is, and it's not a super great way of analyzing data. So the study design was they did 2 online Delphi panels among palliative care and addiction specialists, and they analyzed 3 common scenarios looking for opioid misuse or opioid use disorder. So panel A focused on patients with a shorter term prognosis of weeks to months, and panel B focused on a longer term prognosis of months to years. Participants for the experts were just conducted via personal connections, or if they were members of organizations associated with palliative care, addiction medicine, or both. They were contacted via email, and they were randomly assigned to each panel. So this chart just describes the different cases. It all is based on a man in his 50s with advanced cancer, and he's maximized on non-pharmacological and pharmacological treatments. So case 1, he has no history of opioid use and is not on opioid use disorder treatment and hasn't prescribed any opioids for his pain. Case 2, he has no history of opioid use, but he has been prescribed traditional opioids for pain and has had negative urine drug testing. And case 3, no history of opioid use disorder, but is found to have unprescribed benzos in his urine. So in round 1, the participants reviewed and rated and commented on each of these scenarios and how they would manage the patient. In round 2, they could look at everyone else's comments on how they would manage the patient. And round 3, they gave their final answer on how they should manage the patient. So there weren't great results. Essentially, it was deemed appropriate to begin treatment with buprenorphine or naltrexone and inappropriate to refer to methadone clinics for patients with cancer and untreated opioid use disorder regardless of the prognosis. You could begin split dosing methadone for patients with shorter prognoses of weeks to months, but it was uncertain if you should be doing this for longer prognoses of greater than a year. Beginning a full opioid agonist was deemed of uncertain appropriateness for patients with a short-term prognosis and inappropriate for those with longer prognoses. And regardless of the prognosis, if patients have no history of opioid use disorder but are taking more opioids prescribed, you should be increasing monitoring, but you shouldn't taper the opioid because it could cause discomfort for the patients. And we want to make sure they're being compliant with their treatment for their cancer. And lastly, if you have a patient with a positive urine drug test for non-prescribed benzos, you should increase monitoring, but you don't want to taper the prescription as either. Limitations of the study are, it's a Delphi panel, so it's not great. We do this when there's no randomized clinical trials or other evidence to direct how we should be managing patients. There are no set standards for reporting Delphi studies in healthcare research. There's no validated quality parameters to evaluate Delphi studies. A recent meta-analysis of Delphi studies in the healthcare setting showed that many were of questionable quality. Participant selection can limit generalizability of any Delphi study. And in this study in particular, the participants were asked to self-identify their expertise, and so they picked essentially if they were a palliative expert, an addiction expert, or both. And evidence in the study showed that some participants may have had knowledge gaps, so they weren't experts. Why does this matter? As primary care physicians, we'll be caring for patients with cancer and cancer-related pain, so we want to best know how to approach these patients and how to seek help in managing their pain if you're not comfortable with it. We should be aware of the multimodal approach for managing cancer-related pain, and current guidelines for managing this are based on expert consensus, not great data in any studies. in conclusion, management of cancer-related pain and opioid misuse or opioid use disorder should be individualized based on the patient and clinical scenario. It's a rapidly changing area of practice, and the best practices for identifying and optimally managing non-medical opioid use aren't really defined at this point. And interestingly enough, the use of buprenorphine in patients with cancer does lower their pain scores, but this wasn't statistically significant, so hopefully we'll get more data in the future on how to manage that. And these are my references, so thank you.